Here. So our next talk is going to be from Dr. Victoria Higbie. So Dr. Higbie is originally from Baton Rouge, Louisiana. She is currently a GI medical oncologist assistant professor at the University of Texas MD Anderson in Houston. We actually overlapped a year, right? 1 year? Okay, over at MD Anderson, and thought she'd be an excellent person to come talk to us today. So Dr. Higbie, as I mentioned, originally from Baton Rouge, she did her medical school at UT Southwestern in Dallas and did her residency at Baylor College of Medicine in Houston and fellowship, as I mentioned, at MD Anderson. She's been on faculty there for a couple of years now. And she will be giving us a very relevant and interesting talk on early onset colorectal cancer. And just want to say thank you for coming all the way here, 7 months pregnant, Dr. Higbie. And we are very fortunate to have you.
All right, everyone. Well, thank you so much. In addition to being pregnant, I'm also dealing with a little bit of laryngitis, so excuse me if I get hoarse at any point. But I'm just so thrilled to be here and talking to you guys. This is a topic that I'm really passionate about, and it's really exciting to be here because, as John mentioned, I was born and raised in Baton Rouge, so it's kind of nice to be back and talking with you all today. So my topic today is young or early onset colorectal cancer, which, as many of you know, is a really increasing problem with a lot of increasing public awareness. So I'm going to start trying to identify what the problem is, looking at trends and epidemiology, then discussing what we know and what we don't know about where the problem comes from, considering risk factors, potential etiologies, and then discuss what can we potentially do about the problem, including any treatment considerations. So what is the problem? So as we know, colorectal cancer is the third most common cancer worldwide and one of the top causes of cancer-related deaths. Although historically this is an age-related disease, with most cases occurring in the over 50 population. Early onset or young onset colorectal cancer, which I'll use today interchangeably, is colorectal cancer in patients under the age of 50. An alarming increase in cases of early onset colorectal cancer has occurred in the United States and other high-income countries over the past few decades. Early onset colorectal cancer now accounts for approximately 10% of all new diagnoses of colorectal cancer. And there's an accompanying increase in colorectal cancer-related mortality during the past decade as well, observed among younger patients. In fact, people born in the 1990s are now twice as likely to be diagnosed with colon cancer and 4 times as likely to be diagnosed with rectal cancer than people born in the 1950s. But as many know, we've actually seen a decrease in colorectal cancer incidence overall. So this increase in young onset cases is in sharp contrast to the steady decline in the incidence of later onset colorectal cancer and related mortality over the past 2 decades, which we think has been primarily due to improved screening practices and to a lesser extent better surveillance practices and treatment options. So this concurrent increase in early onset colorectal cancer and decline in later onset cases has actually shifted the median age at diagnosis from 72 years old in the early 2000s to 66 years old at present. In the next 10 years, it's estimated that 25% of rectal cases and 10 to 12% of colon cancer cases will be diagnosed in patients under the age of 50. Trends published by the American Cancer Society on Cancer Statistics show that while cases across all stages are going down in 65 years and above patients, cases across all stages, localized, regional, and distant disease are increasing in patients 20 to 49 years old. And we see the same thing when we look at age and tumor location or subtype, with all tumor sites decreasing in the 65 and above population. And all tumor sites increasing in patients 20 to 49 years old. And in addition to increasing incidence, we also see colorectal cancer creeping up as a leading cause of cancer mortality in the under 50 population. The most recent statistics actually show colorectal cancer is now the leading cause of cancer-related death in men under the age of 50, and the second leading cause of cancer-related death in females under the age of 50 after breast cancer. And although it's been holding steady as one of the leading causes of cancer mortality overall, we don't see the same dramatic increase in older patients. We do see this increase through all racial and ethnic groups in the U.S., but although Black Americans and other minority groups have historically had higher absolute incidence of early onset colorectal cancer compared with non-Hispanic white populations in the U.S., if we look at young onset colorectal cancer rates across ethnicity groups, we actually see the steepest increase in non-Hispanic white population. However, unfortunately, the relative survival still remains significantly worse among Black than white individuals, even among Black patients who present with earlier stage colorectal cancer. And if we look at worldwide trends in the past 10 years, the incidence of colorectal cancer has remained stable or declined in high-income countries similar to the U.S., while it has increased in some low and middle income countries. However, once again, we see while the overall colorectal incidence has stabilized in high-income countries, in individuals greater than 50 years old, it's increased rapidly in individuals less than 50, as we see in the U.S. This increase in young onset colorectal cancer has occurred in both men and women, globally in nearly all high-income countries, as well as many others. So when we look at clinical and pathological features of early onset colorectal cancer, most studies here have been done, they're smaller, single center retrospective studies, don't always systematically exclude germline or hereditary syndrome cases. But despite these limitations, it appears that early onset colorectal cancer presents differently to late onset. Most patients with early onset colorectal cancer present with symptoms, such as hematochezia and abdominal pain, when compared to patients with late onset colorectal cancer who are more likely to be diagnosed incidentally. Patients with early onset colorectal cancer experience symptoms for a longer duration of time and have a longer delay from symptom onset to diagnosis, which we'll talk about a bit in a minute, compared with those with late onset. Early onset colorectal cancers are also more likely to occur in the left colon, including the rectum, and have more aggressive pathology, whereas late onset colorectal cancers are more likely to be right-sided. And at the time of diagnosis, early onset cancer is more likely to be caught at a higher stage. And part of that delay in diagnosis and being caught at a later stage is attributed to screening. So as we know, the age for colorectal cancer screening has decreased in the U.S. from 50 to 45, both by the USPSTF and the American Cancer Society in response to this alarming trend. However, this still leaves a significant population of young onset colorectal cancer patients outside of the screening age window. And although this is a critical part of understanding the delay in diagnosis in young onset colorectal cancer, it doesn't fully explain the problem. In addition to the lack of screening for most young onset colorectal cancer, there are attributing factors to the delay in diagnosis from the patient side, provider side, and the system side. Younger patients may have a lack of awareness regarding their own symptoms and need for further workup. They may also ignore more nonspecific type symptoms. They may put off seeking medical attention due to many reasons, including lack of time or lack of awareness. And they may not have a clear path to access of care. They also may delay due to fear, denial, or even embarrassment of their symptoms. And then even once a younger patient reaches a provider, their symptoms are more likely to be dismissed or assumed to have a benign cause due to their age. And even once a provider is on board and agrees for further workup, there's system delays that include long wait time, more colonoscopies requested than can fill the demand, and often a referral system that requires them to see or consult with a gastroenterologist before having a colonoscopy scheduled. So here lies the problem. We see this dramatic, really alarming increase. We know these patients present with higher stage and more aggressive disease, and we're not sure what to do about it, right? And so what do we know about where this problem comes from? So historically, when we think about younger onset of cases of age-related cancers, we often assume it comes with hereditary causes. And nearly 30% of patients with early onset colorectal cancer have a family history of this cancer in at least one first-degree relative. However, only 16 to 25% of early onset colorectal cancer cases are clearly linked to a pathogenic germline variant, with Lynch syndrome or mismatch repair deficiency and ABC mutations being the two most common. Current guidelines do recommend universal testing of all newly diagnosed colorectal cancers for mismatch repair deficiency and MSI status in order to detect Lynch syndrome. And of course, this also holds an importance in treatment options, as metastatic patients with these mutations would be candidates for first-line treatment with immune checkpoint inhibitor. However, as we see here, the majority of early onset colorectal cancers are sporadic and not attributable to germline mutations. In addition, the rates of these genetic syndromes are not increasing at the same rate that early onset colorectal cancer is. So we can confidently say that the genetic predisposition does not give us the full answer of why these rates are increasing. And really, the increase actually seems to reflect a birth cohort effect, meaning that the younger cohorts carry an elevated risk with them as they age, suggesting more shared risk factors across a generation, in contrast to like a period effect due to changes in clinical practice or something like that. Age period cohort analysis in the US suggests an increased risk of young onset colorectal cancer in sequential birth cohorts starting in 1950, with a continuing rise in incidence in subsequent birth cohorts. As we've seen, most patients do not have a genetic predisposition, therefore it's thought that there must be some lifestyle risk factors such as obesity, antibiotic use, low physical activity diet that may be important to the development of young onset colorectal cancer. And these risk factors can be linked to major changes that took place in lifestyle and social trend during the 1950s. And this graphic is just to illustrate the potential effects of various exposures over the course of a life, right? From even starting in the prenatal period through adolescent to adulthood. And the problem really is that there are a lot of studies done in this area, but a lot of data is conflicting on these risk factors or exposures, and we've yet to really identify a clear cause for the increase. So take, for example, obesity. We know a rising problem. The prevalence of obesity among adults in the US rose from 30% in 1999 to 42% in 2017, with a near doubling of severe obesity during that time. In both observational studies and prospective cohorts have shown that obesity in adolescents was associated with an increased incidence of early onset colorectal cancer and related mortality. However, there have been other case control studies that have shown conflicting results, and only limited data from prospective studies have identified obesity as a risk factor. These studies are a bit limited, as most don't account for things like potential disease-related weight loss prior to diagnosis. Furthermore, we know from prior studies that abdominal fat may be more important than overall body weight in influencing risk of cancer. And really the reality is despite some of these studies suggesting that obesity and other risk factors increase the prevalence of early onset colorectal cancer, for those of us that see these patients in clinic, know that a lot of these patients are of normal weight, of otherwise health and fitness. And so it doesn't quite fit, once again, it doesn't quite explain the entire problem itself. Multiple other modifiable risk factors here that have been associated, some studies, showing associations here, such as sedentary lifestyle, vitamin D levels, of course, alcohol and tobacco use. Sugar sweetened drinks is a big area of interest in kind of the diet and nutrition area, breast milk exposure, antibiotic use, and others. There's also some potential beneficial factors. However, like I said, data remains mixed on most of these, and none of these individually explain the shift that we're seeing. So overall, when we consider the genomic landscape, younger and older onset colorectal cancer do appear similar overall, with kind of expected rates of alterations of several common genes in colorectal cancer. However, there have been studies that show notable differences between the kind of under 40 and over 50 cohorts, and this is specifically in the microsatellite stable population. With some genes like TP53, CTNNB1 alterations seen more frequently in younger patients, APC, KRAS, BRAF, PIK3CA mutations more commonly altered in older patients with colorectal cancer. We know that colorectal cancer tumors with BRAF V600E mutations very well described to be more observed in patients 70 or older, and these studies continue to support that young onset colorectal cancer have a lower rate of those BRAF mutations. And the difference in APC alteration rates is of significant interest, as mutation of APC has been previously described to have an effect on prognosis, meaning tumors lacking mutation carry a worse prognosis than tumors with single APC mutations. And as you likely know, abundant evidence is there that links the gut microbiome with the development of colorectal cancer. Gut microbes interact with the host immune system and can influence the anti-tumor immune response. We know that patients with colorectal cancer overall have reduced bacterial diversity as compared to healthy persons. And there's certain bacteria, Firmicutes, Bacteroidetes, and Fusobacterium that are all enriched in colorectal cancer. In addition, we have seen age-related differences in gut microbial composition as well. And so this is a big area of research right now, trying to understand how the microbiome may play a role. And there are some studies to suggest that we're seeing a bit of difference in both overall diversity as well as the population abundance of different species here. But really, I mean, the microbiome is a really hard area to study in general because there's so much variation and so many things that can impact that. And so definitely more studies are needed to fully understand the role of the microbiome in young onset colorectal cancer. So we know that differences exist across many aspects of the disease between early and late onset colorectal cancer, lifestyle, genomics, microbiome, but none of them completely explain the increase we're seeing, and more work is needed to be done to fully understand. So finally, what can we do about the problem today? So what do we know right now about the treatment of young onset colorectal cancer? Historically, there have been no real clear guidelines on how to treat young onset colorectal cancer outside of standard colorectal cancer recommendations. We do know that stage 2 and 3 young onset colorectal cancer patients are more likely to receive adjuvant therapy, regardless of kind of standard recommendations, and doublet chemotherapy at that. And we know that stage 4 patients are more likely to get surgery at some point. They're more likely to get triplet chemotherapy during their treatment, and they're more likely to get radiation at any point. And so this raises the question, is this because they have better performance status and less comorbidities? Are we trying to treat them more aggressively because they're young? Or is this just really over-treatment? Because unfortunately, despite these more aggressive treatment paths that they often go down, we don't actually see improved outcomes in this population. We do see mixed results in studies, with some studies showing improved survival and some showing decreased survival in this group. These are results from the IDEA trial looking at localized disease, stage 2 and 3 patients. In the overall population, there was no difference in disease-free survival between early and late onset colorectal cancer. In the same population, there was an overall survival benefit in the overall population, early onset versus late onset, keeping with the fact that these are fitter younger patients, but actually saw a bit higher cancer-specific mortality in the young onset colorectal group. In the metastatic setting, we see the same conflicting data, with some studies showing worse outcomes in the younger population, but with many showing no difference. Younger patients are typically diagnosed later, but are typically treated with more aggressive regimens and local therapy options. However, we don't see that play out in a change in outcome. So the Delphi Initiative for Early Onset Colorectal Cancer was a multidisciplinary international group of 69 experts who came together to form the first evidence-based consensus guidelines for early onset colorectal cancer. I'll just touch on some of the highlights here, that colonoscopy is recommended within 30 days of symptom onset, such as hematochezia, iron deficiency, anemia, or unexplained weight loss. All early onset colorectal cancer patients should receive genetic testing, as well as testing for MSI-high or DMMR, which is true for all colorectal cancer patients, and KRAS and BRAF mutations, as well as HER2 amplification, which is true for all metastatic colorectal cancer patients. More specific to younger patients, all early onset colorectal cancer patients should be offered fertility counseling or referral to a reproductive expert. And you may notice what's missing from these guidelines is no change to actual treatment recommendations. So hopefully as we learn more about early onset colorectal cancer and increase trial participation in this population, we can understand how better to alter our treatment approach to this population. But this does kind of bring us to a critical aspect of caring for young onset colorectal cancer patients, and that is unique challenges that these patients face. I do acknowledge not all of these are unique themselves to the younger population, but the combination of these factors add to the burden these patients carry. And these factors include lack of awareness and prompt diagnosis, as we've discussed, possible academic or early career ambitions that have to be put on hold due to their diagnosis, more assistance needed managing employment or extended leave, financial toxicity, nutrition and lifestyle counseling. This is true for a lot of our patients, but especially our young patients are really eager to do anything on their part to kind of help their treatment and their course, and so trying to get them connected with those teams. Potentially, right, if we reach a cure, potentially decades of management of long-term side effects from treatment and need to be able to continue to do their work and to continue to care for their young families. Mental health concerns, sexual health concerns, as well as reproductive concerns, and need for fertility counseling and preservation. Possibly care and support for young children and families. And of course, potential genetic counseling for those with hereditary causes. So really our charge here is to continue efforts to increase education and awareness with the goal of earlier diagnosis for these patients. Continue efforts to improve clinical practice, focusing on the unique needs in this patient population, and to continue efforts to better understand the etiology of this increasing disease population and through research develop better treatment options. At MD Anderson in Houston, we're doing this through a multidisciplinary action team focused on those three areas. Our team includes physicians from surgical oncology, radiation oncology, and medical oncology, as well as social workers, dietitians, patient advocates, and more that are really focused on bringing the best care that we can to these patients. This is a little diagram of kind of some of the resources that we try to get our patients connected with. And these are resources and systems that are available to all patients at MD Anderson. But our focus is when we have these young onset colorectal cancer patients walk through our door, we try to early and often get these patients referred to these resources to improve their both treatment and survivorship of their cancer. So really, in summary, I have to say this is as I mentioned, a problem that's getting more and more public awareness. And really, I feel like the summary is that we still have so much to understand. It's an effort by a lot of people in a lot of different places to try to understand this disease and this alarming trend. But we still have a lot more to learn, and in the meantime, can definitely do a better job of caring for our patients, and that's our goal. So thank you so much again for allowing me to speak.
Awesome. Thank you so much, Dr. Higbie. Any questions for her? Yeah. Here, let me give you the mic.
What specifically about breast milk? Because we've always educated that that's the best,
Yeah.
So just curious.
So exactly, it's more about the fact that I wasn't suggesting that breast milk exposure, sorry. I wasn't suggesting that breast milk exposure increases the risk, but it's one of the factors that we look at. Very well established that breast milk exposure as an infant changes the microbiome. I mean, that's very well established. So it's one of the areas that we're looking into. But yeah, certainly didn't suggest that that's associated with the increase.
Other questions? Yeah, Dr. Ellis.
With these trends, is there an interest in lowering the age of screening or of looking at high-risk cohorts?
Yeah, it's a great question. Obviously, the age has been lowered fairly recently already from 50 to 45. I'm honestly not sure if we're going to get a lower age just based on, it's still a very small portion of our population. And of course, as we know, screening is a very delicate balance, right? With you have to weigh the risk and benefit and things like that. I think hopefully what would be ideal is as we learn more about the causes and kind of what could be the attributing factors, that maybe we could isolate more high-risk populations, right, and have those patients maybe screened earlier.
Thank you.
Any other questions? Yeah, Dr. B, I've kind of thought what would be interesting is, you're seeing more left-sided, more distal in the younger population. Like, could some combination of, a future fecal microbiome test plus a flex sig for high-risk patients, in office, you don't have to take a day off of work, you don't have to get anesthesia, you don't have to do the prep, could that be some combination that could be, for a 35-year-old or something like that? I don't know, you don't have to have an answer to that question,
Yeah.
but something I've thought about.
I mean, I totally agree with you. I mean, I think that it's going to take a combination of understanding the disease a little bit better and maybe figuring out a way to either offer that to everyone or to certain populations of patients. And I think that'll come as we understand it better. I think right now, without those, more advanced screening or earlier screening, I think our charge right now is for awareness and getting patients that are having symptoms in as quickly as we can.
Get your time to talk, Dr. Du, but you can start early.
I'm Ling Du. I'm one of the GI medical oncologists. It's not a question, just up for discussion. I don't think anybody has an answer. I think we, as GI medical oncologists, sitting on the other end, seeing all the young onset colorectal cancer patients sitting through our door. But I used to do hem-onc general practice in community hospital as well for a few years. I think the majority of the, especially young women in their 20s, 30s, presented with iron deficiency anemia is from heavy menses every month. So a lot of times when I still see my lingering patient, I also question, how often should we test those young female with iron deficiency anemia, do colonoscopy? Will insurance reimburse it? Are we over screening all our millions of young women with iron deficiency anemia to colon cancer? So I think all those are up for discussion. I don't think there's a clear guideline how soon we should suspect these are not from menses.
Yeah, I mean, another really tough part of it, right, it would be, this is historically why patients, it takes them longer to get to colonoscopy, right? Because they are assumed to have more benign causes for either their iron deficiency anemia or other symptoms. I totally agree with you, and I think this goes back to the question about lowering the age, right? Is that screening is a delicate balance, right? And we want to make sure that we're not, just screening everyone. That's going to lead to a lot of cost and anxiety and unnecessary tests. But I think maybe as we learn more that there will be ways to include more patients in an early diagnosis or screening policy, I guess.